What's new and what's ongoing in the research of esophagogastric cancer is really trying to build on the signals of activity that we've seen for immunotherapy and other potential targets like HER2, VEGF, and potentially other new mutations, DNA repair mechanisms. Currently, there are a lot of ongoing phase 1 and 2 trials. We have had some disappointing results with some and encouraging with others. I think we anxiously await the results of first-line immunotherapy trials, which we talked about earlier. There also are some other novel targets. The claudin protein, which is a gap junction protein that's overexpressed in most gastric cancers. There is an antibody targeting that protein that may lead to immune enhancement and recruitment, and there was some very promising phase 2 data. A monoclonal antibody that targets claudin combined with chemotherapy in high expressors of claudin translated into improved response, progression-free, and overall survival. Based on that observation, that drug is going to go to a phase 3 trial in claudin high-expressing patients. The use of PARP inhibitors has been a little bit disappointing. There was a randomized trial called the GOLD trial combining PARP inhibitors with paclitaxel that didn't meet its primary endpoint. There was a trend in biomarker-selected patients that there might be a benefit, so that remains a work in progress. There's obviously an interest in studying ramucirumab in combination with other targeted agents, but that's a strategy that's in development. And we talked earlier about novel immunomodulatory agents combined with immunotherapy that may potentially enhance the effectiveness of those drugs. There have been some disappointing trials. There was a second-line trial of an oral taxane versus IV taxane, which was a negative trial. There also was a negative trial of a STAT inhibitor, which potentially targeted stem cells. Paclitaxel alone, with or without a STAT inhibitor, was reported in a press release as a negative trial. And also another EGFR. EGFR drugs failed first line. There was a trial from Asia looking at a drug called nimatuzumab combined with chemotherapy versus chemotherapy alone, which was also a negative trial. So I think right now the excitement is going to be looking at some novel targets like claudin, also developing the immunotherapy space, potentially looking at ramucirumab or other VEGF combinations. There are some late-line trials of VEGF-targeted drugs, randomized trials. There's a randomized trial ongoing of regorafenib versus supportive care, given some promising phase 2 data. And we're about to hear results in refractory gastric cancer of a novel antimetabolite, TAS-102, versus best supportive care in refractory gastric cancer. That trial was based on the promising results in phase 2 and also the positive phase 3 trial for TAS-102 in colorectal cancer.
As we move forward with the gastric cancer understanding of the biology, we have molecular panels that we can use. The question is, whether we use next-gen, whether we use dedicated panels, what gives us the most information, most valued information to impact the care of our patients? What is the true sequencing of the drugs? Can we do better? Can we sensitize some of the disease so that the next line of therapy would work better? What would be that strategy? And that's really based on more biological understanding of the disease. As we have a better understanding of perioperative chemotherapy in gastric cancer, we see that only 50% of the patients in the post-op therapy actually receive the full planned doses, which really limits the chemotherapy they're getting during that period. So the question is, can we move all of their chemotherapy to upfront, to total neoadjuvant therapy models that we've seen in some other diseases like colon cancer? Would that then improve the patient's survival, resection rates, give them better outcomes in the long run? And I think those are that seems to be the direction that we need to be taking in the future.
In the last few decades, we have identified strategies that have improved outcome in the management of esophagogastric cancer. It's clear that neoadjuvant strategies have improved survival. Neoadjuvant chemotherapy and radiation added to surgery for esophagus and GE junction cancers. Perioperative chemotherapy added to gastric cancer improves outcome. We now know that HER2-targeted agents improve outcome in first-line treatment of metastatic disease. VEGF-targeted drugs improve outcome in second-line. And we have a role now for immunotherapy agents in chemotherapy refractory disease. The hope now is to move a targeted strategy forward building on the observations that we have, hopefully identifying novel strategies, looking at the validated pathways such as HER2, VEGF, and immunotherapy approaches, and hoping that our characterization of cancers will result in new hypotheses, new strategies to overcome resistance, and to develop new drugs and new targets.
It's been an exciting evolution to see the multiple drugs develop in gastric cancer. So we've clearly paved the way to improving survival by small numbers, but we really think we have a lot more to do. So we've been fortunate to have trastuzumab, pembrolizumab, and ramucirumab, all the great biological drugs in. But when you start moving them around to first line and start seeing if they can be used in different combinations, the data is not panning out as positively. So it'd be really good to have a deeper understanding of the disease, the biology, so that we can come up with better strategies to use these combinations and come up with newer drugs that would really make a significant difference in this disease.